bring the meeting to order, everyone? Yeah. Yeah, yeah. Yeah. All right, good morning. Thank you, everybody, for coming. This morning, I just want to say too bad for the Mets, but no, seriously, they were underdogs. I don't really care about any baseball team, but I just wanted to see somebody who hasn't won for so long. I think that underdogs are always important. So this morning, I just want to ask that we could have an acceptance of the minutes. They were sent out electronically. Hopefully everybody got to look at them. And please bring forward any revisions, corrections, deletions, or additions. And otherwise, if they're accepted as is, I'd put out a motion to accept the minutes. Any comments, concerns?
Motion to accept the minutes.
And a second? And a second, thank you very much. So in terms of old business, the collaborative committee, Joe Bart out of the northern region, made a really nice video for instructional purposes for spinal immobilization. So if people need to have a program to put out to continue on teaching everybody about the new protocol, you can let me know and I can give you, he's loaded it up on YouTube, I can give you the site and everything. I was gonna print it out for everybody, I'm like, oh, it's just on my electronic thing. So if anybody wants one, please come to me. No negative comment, but it's better than the ones I've seen before. So if anybody wants to use it, good morning, please let me know. And he's put it out there for anyone, so that you don't have to reinvent the wheel or do anything. It's a nice little succinct program. Secondly, from before, we had talked about in the protocols increasing the first line dose of midazolam from 5 milligrams to 10 milligrams when it comes to excited delirium and in certain situations. And the reason why it came up was from this summer and some of those lovely concerts the younger generations go to, and that they really found that they needed this a higher dose of midazolam. So we had talked about it, we had discussed and moved it forward, but we didn't have a quorum the last time, so I wanted to bring it forward to have an official vote. Has everybody read that little kind of, it was just a collaboration suggestion to move the dosage up, and any concerns, any questions, or could we move ahead with a vote? Did you guys read it? Do you remember? It's been so long. It's been 2 meetings ago.
Yeah, I've read it. Have you reviewed the use of Versed in this region? Have you looked at the cases? I mean, is it being used appropriately and you're happy with it?
Yeah, I mean, I think I agree with what
for excited delirium. For excited delirium. Have you
yeah,
looked at
I have
cases?
not had anything come to mind from my cases. I've not had any cases to review for excited delirium, to be honest, in the field. Certainly in the ER quite a bit.
Sure.
But, I don't know if any other medical directors can say.
First dose is 10. It's proposed that the first dose is 10? The
Yeah,
initial dose is 10?
yeah, they wanted to.
Regardless of weight?
Well, I think it's still, a clinical decision, but they wanted to be able to give them that plausible number, because at these little events, and it would be under the specific entity of, a real true excited delirium in an adult, and of course, but it was, they were just running into trouble with managing the cases, and so that's what they were asking for. And it was due to, the stuff up in Bethel, the stuff over in Socrates, the events that occurred.
And the collaboratives have approved it. We are one of the last regions that has not approved at this point as well. Correct?
Correct. We had talked about it and such, but we had to officially vote on it.
Is the language 10 milligrams as the initial dose or up to 10 milligrams?
Up to 10 milligrams.
Oh, okay.
Yeah.
I think that.
Yeah, up to. It wasn't a gunshot of 10, yeah, up to. Just so they had that leeway.
Also, as just a talking point, I know in neighboring counties, they have ketamine on their local formularies.
Yeah, that's in the new, the protocols that are going to be put forth soon, at the beginning of the year or towards the end of this year, that's included. Ketamine's been now added. It's something that has been a very controversial subject for the state, not for us per se. And CMAC has brought it up many, many times. So, you know, we're still taking baby steps here, but we're moving forward. But that's absolutely on there.
There was a study that came out, wasn't there a study that just came out showing like a 40% intubation rate of those patients post arrival?
For which patients?
For
can-
ketamine.
Ketamine,
Yeah, that's like the study out of California, I think it's Oakland.
I mean,
Yeah, they had a high,
I
high.
agree,
Very
there's an
high.
indication
Yeah.
for
There's
it
an
in our
indication for
area.
it.
Are they training
but-
hospitals?
What? Yeah, no, they're out in
Yeah.
the county.
That's just it,
Yeah.
you don't know, I mean, they're from academic centers, and so there is a little bias there.
Yeah, but it wasn't.
It really gets controlled.
Oh, this is a great teaching case.
C121.
No, I just meant they'd be more aggressive to proactively manage the airway instead of watching it carefully. That may, but it does.
Or maybe the ketamine wasn't effective enough.
No, it was.
They were
it
saying
No,
it's like, you know,
it was-
flip side.
was, it was
They were
saying that
getting
the
scared
patient
and
was
then
just
they-
way too,
Snowed.
way too
Yeah.
snowed that they just.
I read the little blip from it, but I didn't read the full paper.
Yeah.
Yeah.
I've seen that paper.
Yeah, I mean, that being said, I don't know whether that, you know, it's one study, and I don't know whether it's really something that you.
I
make a
think
position
there's
statement.
good pre-hospital literature on it, and it's primarily out of Miami. And they describe the entity as super excited delirium, where they have a certain demographic, local population, that is prone to high doses of both cocaine and alcohol simultaneously. So their protocol used 3 to 4 milligrams per kilogram, so very large men were receiving up to 300, 400 milligrams of ketamine.
That's a
And
hefty little dose.
Well, that's
Oh, yeah.
intramuscularly, and then they subsequently, if they still had agitation between 3 to 5 minutes later, they followed up with a subsequent dose of benzodiazepine. So their overall intubation rate was less than 2%.
To your point, what they showed in the study was the patients that were over getting 5 milligrams per kilogram or greater were the ones primarily getting intubated.
Sure, the dose matters.
It does. I don't know, what's our dose that we're,
I think they're talking the 1 to 2.
That might be very low.
or, yeah, that's
Yeah.
fine,
Yeah,
sure.
You know.
exactly.
For the sake of this
They may just call
discussion,
again.
we're mostly talking about Versed as
Yeah,
far as
yeah, we just went
approval.
off a little bit on this.
Yeah.
The only thing I would like to comment for the record is just that the ketamine, when that does come up, I know not having a rescue IV is, giving IM ketamine without a rescue IV can be a recipe for disaster sometimes, just because of the laryngospasm that can happen with that medication, 1 out of 1,000.
I'll add that comment to the,
Fatal,
to the-
they can have laryngospasm with that.
yeah, to the committee.
But-
I have not seen the final product to say this is what it said, but, I'll add
Sounds
that.
good.
Usually ketamine is a bridge to
I'm
getting
sorry,
the last
I don't know
to get
who
an
that
IV.
is.
That's,
sorry.
that's kind of
I-
the goal, you know, the hope. So I mean, if they get it last enough, so you can get an IV, they can slip it in real quick if that works. But
I'm not sure.
Not at our hospital, that's the problem. And it's banned at our hospital for giving IM ketamine without a rescue IV. And for that reason only, because 1 out of 1,000 will have a laryngospasm where you wish you could relax them with something other than an IM medication. So that's just my 2 cents, my 1 cent maybe.
I'm sorry, I'm actually introduced. I'm Johnny Kwan. I'm representing Nyack Hospital for Dr. Shaw.
Okay.
I'm the associate director. Dr. Kwan.
I'm sorry, Dr. Kwan?
KWON, yeah. Hi everyone.
We were wording our second delirium protocol at our hospital, it's not published yet, but as the indication is that actually it's a conscious sedation procedure using ketamine for the purpose of putting somebody in restraints. That you can't
For the
otherwise
purpose
get.
of what?
Putting somebody in restraints that you otherwise can't get in restraints because they're so out of control.
In our national protocols, it's for sedation, 0.5 to 1 milligrams per kilogram, with a repeat dose in 10 minutes if ineffective. And they also have other options, whether they're carrying midazolam or lorazepam or diazepam, or they have those as well as options to use as a sedative.
So, to what you were saying, the protocol as proposed though is, it's a max of 10, but they're gonna be starting at the, 5.
Yeah, up to.
Regarding-
Yeah, just so we can give them some leeway in certain clinical pictures. It was not, the gunshot, yeah. But especially after these attendees and these events that occurred, that's where this came out of, just to give them some leeway. Michael?
Just a point of clarification, we're reviewing the current protocol that we're currently operating under. Ketamine is in the protocol today.
Right.
3 to 5 milligrams per kilo IM, paramedic order only, and it's not a required medication.
Yeah.
So
No,
that's
it's
why
not.
I don't think a lot of people are familiar with it,
Right,
because it's
it's
not
not-
a mandatory medication.
Exactly, that's what I meant by that, but it's going to become part of the protocol as standing, going forward with the new ones they are. But right now, no, we don't even have it, so.
Well, but it's optional.
It's
It's
optional.
physician option,
Yeah.
Right, it's physician option based
and no
on,
one carries it.
based on the agency, really,
I don't think we've had anybody
that have put it in.
put it in yet. Not in our region.
I know in Westchester it hasn't been used, but we've reviewed the cases that they use, several cases, use it with the use of Versed.
I think the largest data set on the planet is from Hennepin County, Minnesota actually. They're leaders in ketamine for excited delirium. So they presented at ASAP 2008 cases of pre-hospitally delivered intramuscular ketamine, and their intubation rate was less than 1.4%, something along those lines.
Yeah, I think that, they want to make it more incorporated into the system, so that's what they're looking at right now, but I don't have that preliminary info. But again, it's to push it forward, that people can use it and have it if it's available.
So we have a motion?
Yeah,
for-
yeah, so I'll make a motion that we accept the new revision to the collaborative protocol for excited delirium, that the initial dose of midazolam can increase from 5 milligrams up to 10 milligrams. All those in favor? Okay, so it's unanimous. Thank you. I'll come back to the collaborative protocol update under new business, because there's some stuff, we had a conference call and things, so I'll bring that up in a little bit, but I'll stay in the order we have the agenda in. So RTAC, Dr. Berkowitz.
I can talk about Artax. So, a couple of things came up. I think, first of all, I don't know if there's a quorum here, I can present this again. This came out of the Artac.
There's a quorum.
Yeah, was there quorum last time?
No.
Yeah, so, I don't know if we need to vote on this, but this is the decision guidelines that, came out of the RTAC the last time around. You can pass them around, it's basically this one is just basically using the CDC field triage guidelines. And then, this was, straight from the RTAC, with a couple of, with including pediatrics, and then some specific criteria for TBI. That based on our evidence, the RTAC agreed would be better off going right to a higher level trauma center. So we can pass these along. The other thing that came up, there was a long discussion of immobilization. A couple of things that came out of that. First of all, I think that, I've noticed clinically that that there's been a fair amount of patients who have been coming in with C-spine immobilization without backboard, which is fine, but who are sitting upright. Anywhere from 30 to 45, even more, but pretty significant mechanisms, including a patient who's actually quadriplegic from an accident and was sitting upright, which probably doesn't probably isn't the, I wanted to see what people here think about that. Should we be keeping these patients in spinal motion restriction, but without a backboard, or should we just let them sit up?
So I said at the RTAC, they should maintain spinal motion restriction during transport.
So, what do you guys think? Do we think that, you know, if you're, should we not use the backboard, but lay the patient flat? Is there any disagreement with that?
Well, the guidelines on the spinal mobilizations is that you can sit them in and not at a 90, but at a 45-degree angle.
The literature that wasn't completely clear. It was,
Right, yeah.
the slides and the, you know, the exam and what was said were conflicting, so it was not clear at all.
Yeah.
If you look at Bart's video though, it makes it much clearer, to be honest.
What is Bart's video?
The one that Pam
Yeah, I know
just
what you
spoke
mean.
before.
Yeah, I'll give you the website so you can look at it.
He's got two videos on there, the two 20-minute presentations each, and one is frequently asked questions, and the second is live demonstrations from Oriskany. You know, so, and he went over everything, the do's, don'ts, and, you know, will someone get castrated if they bring somebody in on board and that kind of stuff, so. It lent a lot of information to what maybe wasn't presented in the WebEx.
And what is in that video? What does he say about?
Basically, they could be sitting up, you know, the 45-degree angle position of comfort, based on the Nexus studies.
If they're based on the Nexus study,
Well,
if they have a neurologic deficit.
He referenced Nexus and the reasons behind why this is happening. And he basically said you don't have to bring them in on the board, they don't have to be, you know, always lying flat.
Well, but Nexus, I mean, the Nexus criteria means you need to have a normal neurologic exam. If you have patients who have neurologic deficits or altered mental status or distracting injuries, then I think that maybe they should have spinal motion restrictions.
Yeah, I think what the way it's set up is the clinical decision has to be made that if you really need spinal immobilization, then you leave them flat and you immobilize them. They don't have to be on a board.
Yeah, exactly.
But they can still be
Flat.
spinal immobilization restriction.
Yeah,
I think
exactly.
is the proper
Yeah.
term. But again, it all goes down to like clinical mechanism and what they have for an
Can I ask
exam.
a clarification question? Is spinal motion restriction is only considered if the patient is flat? If the patient's at a 45-degree angle and you're not using spinal motion restriction? Because that's contrary to everything that's being distributed out there. That's just the question I have.
And that's why I'm raising this question, is I think that there's some confusion on what should be happening in these scenarios where patients are unable to be cleared, and they are, you know, should be transported flat or should they be transported sitting upright? Clearly, it sounds like the education has been upright.
I know, does anybody know the medical evidence? I honestly don't know, you know.
Yeah, I should.
Arshad, I'm gonna come to you, you're like the
Yeah.
C-spine guru.
Yeah, so there's so many
Flat up there.
there's so many articles that have come out in terms of is the supine position the ideal position for maintaining cervical spine immobilization. And there are 3 recent studies out of Europe that have actually patients who are vomiting yet have altered sensorium as trauma patients in the left lateral decubitus position with the cervical collar in place. And there was primarily retrospective data. There was a very low incidence of cervical spine fractures, which we know is the same with our trauma cohort. And there were no additional injuries noted or neurologic sequelae by positioning the patient in the left lateral decubitus position. So do we have good evidence out there? Not really. Can you probably raise the patient up 15, 20, 35, 40 degrees? I don't really see why not. You have the collar in place, and what if they're vomiting, you know what I mean?
Oh, well, sure, no, I obviously I think that if there's always a situation where,
Yeah.
I mean, if they're vomiting, you know, if they're gonna aspirate, they're gonna die from aspiration, that's obviously a much bigger concern.
I think especially when we come to spinal immobilization, is that the more comfortable the patient is, the better the immobilization will be. In other words, we thought backboarding patients was a good idea, yet they were so uncomfortable that in fact, they were moving around more so. Same thing with cervical spine immobilization, we'll have the splint there, it's more physiologic, as opposed to the long backboard, but if they're just more comfortable at a slight incline, I think it's probably gonna be protective.
Andy?
Well, I just think that lacking a Remac advisory to the contrary, you're gonna be left with whatever the state has put out.
Sure.
It's gonna be that they will
Sure.
obviously have that shows elevated, so you have to raise to the level of indicating this is of concern to Remac and have an advisory. If not, it's gonna go the way it stays now.
I mean, I think what I'm gonna do is I'm gonna take it back to the RTAC and let them say what they think is, you know, should patients be coming in, you know, slightly up or not, and, you know, and as well as take a look at the literature, but it's definitely happening.
Yeah. I think it's prudent to say that if somebody's got a neurologic deficit, it would seem intuitive to keep them flat.
Yes.
I don't, I mean, I think we're in an area, like I said, where there isn't good medical evidence one way or the other, whether you're gonna cause more damage, but if somebody's got a burst fracture to their spine and their paraplegia, their lumbar spine, and you sit them up, you know.
Yes,
I don't know the
that was kind of where I kind of started to say this seems to be maybe the question is whether the pendulum swung when a patient was brought in as essentially quadriplegic and
I think,
sitting upright.
and the other point is, in the face of a neurological deficit that they found and seen, you're not gonna get the question, they're gonna probably put them on the backboard again.
Well, and they're allowed to, I mean,
I know,
hopefully,
right,
that's
right.
the way it's
What we're
supposed to
gonna
be,
have is-
but is there any fail-safes? No, but they're supposed to. I mean, but that's where the problem came, from all of the immobilization data or concerns was from the trauma surgeons who said, what do you mean you're gonna take away the back? Our guys went ballistic just recently of a case that came in, and I didn't think they had any real mechanism of spinal trauma. And he was so taken aback that there was no backboard. And I think, you know, still the trauma surgeons are still out there saying, you know, they're still uncomfortable removing backboards.
Our trauma surgeons don't have an issue with the lack of a backboard. I think that we've seen enough bed sores.
Yeah.
Honestly.
Yeah.
Because from long transport to never want to see a backboard again. I think that the question I have is you know,
Positioning of that.
Is positioning, when should we be positioning them flat? When
And
should
I'm
we
not
be
sure if there is data out there of, because it's so new, as do we have enough of spinal restriction
Yeah.
versus, you know, putting them in, you know, 30 degrees, 40 degrees, or, you know. I can't imagine having them sitting bolt upright though. Like Mark just said, if there really is a neurological deficit, I would think they would still be using some device to immobilize their lower spine.
Yeah.
Or restrict their lower spine movement.
So I think that's just something that we need to keep on looking at. Another
Yeah.
thing we talked about with cervical mobilization was, so we discussed our institutional protocol for receiving a trauma
I'm
patient.
sorry, I lost you, Dr. Burke.
Our
Discuss.
institutional protocol for receiving an interfacility patient is that we never assume, we never take another institution's C-spine clearance as being official. Which, from the trauma center perspective, and all the trauma surgeons would say, we're like, of course, kind of just as you'd expect. They're all saying, of course, why would you expect someone else? I'm not gonna take someone else's clearance as my own. And the way that plays out is when patients come into our institution, if they don't have a collar, and their mechanism would have warranted a collar, they get a collar put back on them, even if they've been cleared. Which has led to some element of conflict, or disagreement about why we're doing this and what we're doing this. So the first thing that I did is we sent out an advisory explaining why this happens, and why EMS certainly should take their orders from the sending physician. If the orders say their C-spine is cleared, that means their C-spine is cleared, and that's the right thing to do. And that our institutional right thing to do is to follow our processes, because that's how you don't have missed injuries. At the RTAC, there was a discussion over whether they wanted to make a recommendation to that for all interfacilities, that cervical mobilization be made, that be maintained until the ultimate destination receives the patient. I don't think we voted. Did we vote on that? We did vote on that, right?
We voted yes. We'd like to recommend
Yeah.
that all hospitals that if you're sending a patient to a trauma center, leave them in or put them back in a cervical collar for transport.
Yeah. Basically to avoid that scenario. I think that the RTAC was also gonna release some guidelines, or what is used to clear in the hospital C-spine. But, you know, I think that was voted on. I guess I didn't get the language. I asked them to send me the language and I never got it. So, that was there, and that's kind of open for discussion to see. I wanna see what people here think, about that. I think it's a really complicated issue. And I think that I can see there's a lot of ways of seeing it. Certainly, if you as a treating physician in a hospital see a patient and you think the C-spine's clear, it's not really fair to you nor the patient to say, well, I think you don't need this device, but I'm gonna leave it on you because I know the other guy wants it. And we certainly don't want to interfere with that care that's going on there. At the same time, it's really important that when people come into our institution, that we follow our processes. And our processes are there because we do occasionally find missed injuries. We do occasionally find, either inadequately imaged, misread. I mean, there's a bunch of things that have been found over the course of years that lead us as a trauma center to want to not to assume that the cervical spine clearance that was done completely, and the best way that we found to ensure that is just to assume from the get-go, de novo, that everything needs to be at least considered. So I just wanted to put that out there. What do people think about that issue? Anyone?
Is there any data on the difference of patients that come in that actually have missed injuries?
On their outcomes?
I'm just curious, I have no idea.
So the outcomes data, in terms of whether they suffer neurologic damage, I mean, I would be highly doubtful that there would be any patients who would have suffered a neurologic injury from that. I think that the likelihood of a missed unstable injury is much lower than the likelihood of just a missed injury. But when you have patients who are come to the ER and then going up to the operating room for the orthopedic procedure, and the anesthesiologist is then manipulating them a fair amount, and there's a lot of stuff going on, and then you find out later on that there was a missed injury that's even stable and not a big issue, it does make the whole system want to try to identify those patients at the beginning and not have that. And not have those things happen.
It makes sense what you're saying. I actually have had a couple patients we've sent down there, and I was like, oh, they made you put the collar back on, because I had done a scan of the neck and cleared them. But it makes sense what you're saying.
Yeah.
Unfortunately, it is duplication.
It is
I don't
duplication.
I don't know how else to get around it, though.
Well, when we saw your advisory, again, we're trying to figure out, okay, we are gonna take the orders of the transferring hospital's physician.
Absolutely.
Hopefully we'll try to get something in our notes that says who pronounced the C-spine clear. We're gonna get down and prepare the groups for the fact that Westchester's gonna put a collar back on them. Some anxiety about, okay, we just went through this whole transport, and now we got a collar back on. My question is, normally there's gotta be usually a contact between a transferring and accepting hospital. Wouldn't it be more prudent if, in that discussion, the order is placed to put the collar back on the patient?
For the transport. I mean,
In that
we
case,
could make it of that.
It would make us feel a lot better, basically. And again, I just think that if it's part of the transferring order, from the receiving hospital to the transferring hospital, it eliminates a lot of the issue, I think.
So, and we have raised that as well to start having our trauma surgeons recommend to continue C-spine mobilization. That being said, we don't, the receiving hospital doesn't make any orders to the patient is there, the sending hospital's patient until they get to our campus. Everything that happens, until that moment is if we accept the patient, we're really just saying, hey, we can take care of the patient. You said you can't, bring him to us. So we can make recommendations, and I am just encouraging our surgeons to make that recommendation, but it's certainly not going to happen in every case. And there are a lot of cases where the patients are either fairly ill or there's a lot going on, where it's hard to kind of stick it in there for each one.
Well, I understand, but it just seemed to me that it would be cleaner for everybody if there was an agreement between the transfer and the receiving hospital to place them back on a collar for the purpose of the transport.
I can see.
And like we have to understanding orders for certain things, it just seems.
If we had cleared somebody clinically, then I can understand why you might be reluctant to accept that. But if the patient's already had a CT you know, surely there's a mechanism that we could upload those images so that your radiologist could even be looking at it while the patient's en route, so that they're cleared by you, cleared by your radiologist before the patient gets there.
But the clearance involves the clinical evaluation. It's not just the radiologist.
Right, but, you know, I mean, I imagine it, like, I'm just putting myself in the, you know, patient's shoes.
Sure.
If I've been seen and scanned and it's, you know, it's negative, might there be like a tiny miss rate of, you know, less than 1% maybe, but I agree with you. I think that the likelihood of missing something that's clinically relevant in a patient who's had a CT is probably pretty small. And it would be frustrating for me to say, wait a minute, you know, you just told me my spine's okay, why do I have to put this thing back on for an hour and a half ride down to Westchester?
And that's, again, I agree exactly with what you're saying about some of this, but you know, there's no really good way of, without, in the absence of the exam, there's no good way of really saying someone's spine is clear. And that's why in the advisory and all along I said it's really the sending doctor makes their determination, and then we follow our institutional processes.
So when they hit the door, you're gonna follow their institutional process, because that's your
That's what we do.
fail-safe. Yeah.
That's what we do.
Yeah.
And I think that a better way, or at least the way I like to think of it as, is that we be aware that this is kind of how we operate, and it's not about mistrust or about anything. It's about, you know, that we.
Your protocol.
This is our protocol, and you know, the ACS has looked at us, and when they come in and they verify us, they look for missed injuries, and they look through, you know, buckets of charts, looking for anything like this. And things like, you know, a patient who comes in where they say C-spine is not immobilized, and then later on they're found to have an injury, they would ding us for that. And so, how are we going to prevent that from happening?
Is there some standard that could go out to all the hospitals that they could follow, or?
You know, a third come from non-trauma centers. There's a fair amount of variability. I think that the better way of thinking about this is that when we put the collar on back on, it's not because they don't have that there's an injury, that there's an issue. It's actually just that this is our process,
Yeah.
and usually it comes off within half an hour to an hour. But while the images are being evaluated, while everything's being done, they put the collar on, and that my feeling on the matter is I just want everyone to be open about it, so that no one feels that that we're either duplicating or not trusting, that we're just following our processes, because we don't want to have, you know, we're held to a very certain standard for the American College of Surgeons, and that's really good for us. That's really forced us to become a better trauma center than we would have, you know, than we would have been without it. And but one of the byproducts of that process is that we need to be really need to, you know, dot our I's and cross our T's, and this is how we do it.
Dr. Van Wilkins.
Yeah, so again, I don't think any of us have a problem with a recommendation or even a strong recommendation. I think then the issue is on a case-by-case basis. Some patients have CHF, COPD, and how they're immobilized can make an issue potentially. If we've clinically cleared them, you know, we're going to let them know that we might leave the collar on because we want to be absolutely certain. This is a little different than putting somebody on a backboard, which is what we were doing 10 years ago. Every patient that was, you know, sent to a trauma center was put back on a backboard and left on it. So I think that that's a little bit overboard. I think the whole issue of how we immobilize them, I think is reasonable. You guys have to make sure that there's not an issue. So we don't have a problem with it being a strong recommendation. I think the point about, hey, when you're accepting the patient, you're talking doc to doc, say, hey, listen, you know, they had a major head injury, why don't we keep them in the collar even though everything's cleared? And we'll make sure that our places, you know, are aware of that. There'll be some cases where we probably won't want to do that, but it'll be on a case-by-case basis and will be discussed.
Fran.
I think the issue also is the patient, but if we explain to a patient that, look, we think you're clear, you have a CAT scan, but there's always a chance you can do some missing, and the accepting hospital wants to be 100% sure, you know, we may put a collar back on, or they for sure will put a collar back on, this is protocol, and just educate them, and I think that would be fine. I mean, most patients and patients' families want to make sure, you know.
Yeah.
So I think it's a matter of education. If you need to, I mean, I understand, what, you know, that you need to be 100% sure, and in the Russian stuff, weird things can happen. I mean, a CAT scan is very good, but clinically, things can happen. There can be injuries with a negative CAT scan.
Absolutely.
So I think, you know, it's not so bad to put a collar on, and especially just discuss with the patient. You know, this is what's protocol for the accepting institution that's a higher level of trauma, you know, and that's.
I agree 100%, but education is not just communication. I mean, I think that the worst situations happen when people aren't communicating about this.
And I think the other thing that you can educate the patient on and have the communication and discussion about is, we're gonna put you back in an ambulance again, and now you're gonna be transported again, just for safety. That's also an issue, to put you back in the column for that transport. Dr. Kwan?
So a couple questions. One, I mean, just a rough estimate. Do you guys
Dr.
usually-
Kwan, can you raise your voice
Do
for
you
me?
guys usually re-scan these patients with a CAT scan?
No. So
Oh, so it's
they
not-
don't get re-imaged. So the process there is that, you know, all the images, if you're on our regional packs, which a lot of the hospitals here are, they're uploaded, and then the official the reads at the outside hospital are compared to our radiologist evaluations, and then a decision is made whether to accept the outside reading. And if there's an issue, then they figure out what to do. Sometimes for C-spine, if there's an issue or question, they can get an MRI. And sometimes, rarely, patients to be re-imaged. We've actually cut down on re-imaging a lot the past 5 or 10 years, mostly because regional packs, and I think that the quality of the films we're getting is better in general.
And the other question is, I mean, I don't know if you guys accept a lot of penetrating trauma, but if you have an isolated penetrating trauma nowhere near the C-spine, is that still an indication for?
No, yeah. So I mean, the ACS Committee on Trauma, C-spine. I mean, it's pretty clear. Yeah, I mean, penetrating trauma. I mean, people are very cavalier. You know, I would almost say, to some extent, with penetrating trauma. You know, you first have to ask, like, do you only get shot, or do you get beat and kicked too? Because sometimes it's like they kick you and they beat you, and then they shoot you. But yeah, generally isolated penetrating injury that's not near the C-spine doesn't need to be immobilized. Mike, I'm sorry. That's what I hear from
I just want to throw this out on the table. This is patient education. This is obviously Westchester's protocols, and we respect that. So our crews, when we saw the first notice, have been educating our patients on the way down. Listen, when we take you into Westchester Medical Center, you're considered a new patient to them, even though you've had these tests and your spine has been cleared. They're gonna redo it just to be on the safe side, so they're gonna be applying the neck device that was on you a couple hours back, you know, in the ER. I think that if we do it, we're doing it, Mobile Life does it, all the transport EMS agencies do that in a trauma case, as far as educational purposes, then I think we're good. I don't think we need to have our patients transported for an hour plus in a cervical collar that is uncomfortable and may not be necessary when it's a simple educational process of our crews, the paramedic and EMT saying, listen, when we bring you in there, let me give you a case in point. This is a little bizarre. Helen Hayes Hospital, in their admission process, asks everybody, have they ever been a coal miner? That is part of their admission process. So you can bring in a 79-year-old grandmother, and they will ask her straight-faced, have you ever been a coal miner? Have you ever been diagnosed with black lung disease? We educate our patients when we transport them to Helen Hayes. Listen, they're gonna ask you some very bizarre questions, but it's part of their process.
Do you know Patsy Cline?
So I think that we can do that with our patients. I think we can, if
Yeah.
we know that this is gonna happen.
That's the standard.
We can educate our patients on the way down, and we don't have to go through the rest of the discussion that, we'll take care of it.
Well, I think we have to get the information out there because, you know, I think people can misconstrue, oh, they don't trust us, you know, they're
Yeah.
doubting us, they're second guessing us, but, you know, that makes perfect sense of what you're describing, that you have an institutional protocol you have to follow, you're gonna clinically clear the C-spine, doesn't necessarily mean they're gonna be re-imaged, but, you know, you want to make sure everything's, you know, right.
Oh, yeah, they're rarely re-imaged, rarely re-imaged.
If you wanted to write a simple patient education script for everybody, we'd be more than happy to disseminate that to patients.
Okay, I can work on that, I think that's a great idea. I think what you're doing sounds like it's really helpful and I really appreciate it.
Like Miranda cards, you know, we'll just read it.
With your name and phone number on the back.
Exactly, if you have any questions.
Anything else from our tech, or that's it?
We got the lawyer part about being there.
I think that's it.
Okay, great, thank you so much.
Before we move along, did he need a vote on the adoption of those documents that you passed around? Because I think we passed over that if you were intending to have that done.
I think
In other words, how do we
those
go
are-
about
yeah.
distribution and education of field and then getting those into the collaboratives?
Well, the collaboratives have already taken the field triage, that's already in there. That's in the new stuff that they're looking at. The pie diagram, I don't know, I have to check on that, but definitely this was taken towards collaborative already.
Okay.
Since this is more our region, I would think it stays more within our region. But why doesn't everybody look at it, we'll put it on the agenda, and we'll, you know, I'll get it clarified. But it brings to the table the issues of regional stuff versus the collaborative stuff, which we'll get to. But we can always do regional approved issues that you want, because every region's different, as we talked about when we joined collaborative. Okay, next on the agenda is service upgrades, there's none. Evaluation subcommittee report, Dr. Brooks?
Nothing active?
Okay. Helicopter committee, Dr. Stu Miller?
There's been no business before the committees.
Yeah, we had your report the last time, it had all that. And that was from the last meeting. Quality improvement, Jeff?
Okay, biggest thing we've got going on here is EPCRs. Several agencies have taken the jump, including Transcare. Northern Dutchess paramedics will also be up. One of the things that has been problematic is the delivery of a hard copy to the ER. The state is aware of that. The agencies have been made acutely aware of that. We've had a number of discussions with ImageTrend as far as being able to accurately get the data where it needs to go. Part of that issue is obviously going to be a cost issue to the hospital. We've been working on solutions for that. Mike Taylor from the state has been well involved in this. There is a local vendor in Fishkill that does electronic health records, and they have now entered the arena to see what they can do to put the data where it belongs. So it's an ongoing issue. No imminent signs of resolution, but it's being worked on. The move to the Nemesis 3 bridge, probably by the end of June next year is what we're looking at. Most of the EPCR vendors have been placing Nemesis 3 data elements into what they're doing now, just to make the transition a little bit easier so agencies don't get hit with a huge upgrade all at once. There has been an issue with Zoll as far as the data that's been going up to the state server. They had a large group of data essentially stuck in the queue, and that has kind of slowed down the actual validation reports. It's not that it's not getting there, it's just kind of spinning until the data gets out of the queue. And that's pretty much it.
Question, what's the cost issue to the hospitals?
Several $1,000s, like 18 to 20,000.
To do what? Right now, I provide a fax machine, a printer, all right, and I'm still not getting it.
And
there
we're,
should not be an additional cost.
what they are looking at is actually placing the data into the patient records in a seamless manner. So that is a software cost.
That's part of the EMR, and that's down the road. There
Yes.
is a program to do that, but right now, I'm still not getting
And we are still working on that.
Yeah, one particular agency.
And we are still
Ever since they-
working on that, yes.
Jeff, is this state bridge something that any EPCR user will be able to dump their data into and provide a report to the hospital?
You already have access to it,
Okay.
so, yes, you can.
So at their point of service, when they drop the patient off, when they upload their EPCR for completion, it'll then
If it's,
transfer through the straight bridge to the hospital?
not directly, no, and that's the interface that they're working on.
Okay.
You can see the data, you can print the data, obviously, but it's not being integrated. And that's the part of the puzzle that they're still trying to work on.
Okay. We've been working on this in Dutchess with ESO, trying to get hospitals up with that.
Yep.
Same idea.
Yep. And the positive end of that too is if we can put data in, we can also get data back out,
Sure, right.
which would be a tremendous benefit to kind of closing the loop with QA/QI.
Absolutely. For the providers.
Yes,
Albany Med already does that.
yes, they
You
do.
take a patient up to Albany Med, like Diaz, you take a patient up there, by the time they get back, they have an update on their patient.
Yeah, I think that communication going both ways will be so helpful. And to make QI for everyone a lot easier, and actually probably more productive, because we'll have real-time numbers,
Yes.
hopefully. Okay, thanks. So under new business, this brings us back to the collaborative protocol. Because there was no CMAC in September, we didn't have a face-to-face meeting, so we had a phone conference call. And quite a few issues were brought across. And just FYI, anybody can call into these meetings and be part of the protocol meetings. I think that there's a lot that goes on electronically so that you can, have updates, you can look at what people are discussing, what ideas people are putting out. There is no formal mechanism for ideas and additions, deletions, things to add or subtract from going forward. However, I'm gonna bring it up to the committee to say, could we have a formal kind of electronic methodology for people to put stuff in? Because right now, we just send back emails back and forth. You get these emails and sometimes I don't know what happens to them afterwards, of what the discussion has been and what people are working on. So the first thing that was brought up at this meeting was how to facilitate making this a more organized approach so that the information gets out there and we're all on the same page and everybody knows what's happening. It's difficult because of the size of the region and it's not an easy process. And as we all know, the last time we rolled out the protocols, there was a little bit of a lag in communication and ability to get things. So we're trying to make it a more seamless process. Tim from Remo is spearheading that tag, let's say for lack of a better word, to look at what's the best process we can do this, so that we all get the information. I think that from conversations I've had with people, there is no kind of secretive society here. Anybody can go on and be part of these conversations. And if you go to CMAC, there's always a face-to-face meeting. So you guys are welcome, and to put forth information, we have to have a better mechanism so that it goes right in and everybody can see what the ideas are and the suggestions. So that's something that we have to facilitate. The other thing that is a big topic of discussion is the whole process of collaborative protocols and your regional your Remac, like our Hudson Valley Remac. If we want things to be a little bit different, or if we don't want to adopt certain things, how do we do that process? And how does it remain all legal and such? So there is a small group headed by Dr. Cushman, who's looking at now that process, the governance and the procedural process of how we can keep this all functioning and keep it legal. And will there be some kind of memorandum of understanding legally of this is how we're gonna work it. But the bottom line is, any protocol issue from the state, they look at it that our Remac is responsible. So we can be a member of the collaborative protocols and a member of the institution of collaboration, but if we need to change things, if we need to advise things, if we need to do things, because every region's not the same, we can do such. We just have to do it in the proper procedure and vote on it and have, everybody in agreement or majority. So these are all things we're looking at because we didn't realize how big this was gonna get so quickly. However, the other caveat there is they don't want people in and out of the collaborative protocol system. So we're gonna look at a methodology of once you join, kind of like the military, you're in there for a period of time and you do it. You don't jump in and out, in and out, in and out. And we just come to some mechanism that we can all discuss things and make it work. Because I think, there's no sense of reinventing the wheel. If we can work on things together, we can do things together, improve together, it works a lot faster, works a lot easier when we come as a group to the state, and that we can have many more minds thinking alike or bringing up other issues that we can all talk about it and make it the right thing. So that's the principle that they're working on. It's tactically going to still take some work, but we're gonna have another face-to-face meeting in December.
Part of those discussions, are they about credentialing between the regions?
Oh, one of the things, that was not so much as that the collaborative committee cannot interfere with our credentialing process. That each region has to have their own credentialing process. I don't know if it included that. I had to hang up on the meeting. I was at my CME, so I had to hang up on the meeting, so I didn't get to finish it. But I'll ask that question because they were talking more about that the regions retain all their administrative issues. You know how we have it in a manual, our separate administrative manual, that you keep those things separate. They shouldn't be in the collaboration protocols. Those kind of organizational and way things work should remain separate because it's not part of the collaboration. But that the credentialing between areas is very important and it should be in there. I think that should be something that we do under the MUO. Okay, and so a couple things people have brought up, they want to put patella reduction in there as a new procedure for ALS. One of the regions up north is putting that through. They're going to introduce it as a physician option. New York State's not too happy about that. Just FYI. I know, straighten their leg. We have three working side groups. One working on diabetic emergencies, end of life termination, and again, the excited delirium chemical restraint thing is a big one. The working groups did not have anything new for me to pass along at this time, but those are the functional groups right now that are working forward. But again, if you go to CMAC, you're at CMAC, please, get in touch with one of us, especially Dr. Daly will decide when we're having the meeting. Is it the night after CMAC or before, so that we always have a face-to-face meeting. But we have to facilitate that communication and the delivery of the information both ways, coming up and going down. So that is something that we're looking at. Unfortunately, we did not have a CMAC in September, and the next one's December 8th and 9th. So we did not have a face-to-face this past, in between the last meeting. Any questions, any concerns? And again, I can give you, anybody wants the email, I can give you, put you on the email group, I can give you the email to write in, and so that you can get these updates, periodically when things are being pushed around. So there's also, they're looking at some new drugs, dexamethasone versus solumedrol, adding Tylenol liquid in the field, and a question of just some different medicines. Some of them, Tylenol liquid, some of the medics came on and were saying, quite vivaciously, like, we're gonna have to measure a liquid for a patient, like, just treating fever in the field is one of the issues. Sepsis is a big one coming up in terms of how do we institute sepsis protocols in the field, and that's actually being worked on by one of the physicians in the group.
We don't take temperature.
Yeah, well, that's what they're looking at.
That's what we're trying to do, is get thermometers.
Yeah, that's what they're looking at, is the whole thing, that would be the first step. Yeah,
That would be.
yeah, yeah. Not a mummy temperature, yeah, and no putting your lips on their forehead. Yeah, so those are all the things that are coming up. But again, you know, any kind of input, anything that people want, please let me know and I'll make sure you're added on, and I can give you the email address and the collaborative committee. So next, under new business, we received a notice from the Department of Health that they were investigating an issue at BVAC, and through multiple phone calls and investigations, the state had to act pretty aggressively because there were some issues with their narcotic process, and in conference call with myself and Eric and the office here and with the state, we had to put their ALS status on hold for a period of time to allow them to remediate, to work with the Bureau and the New York State to rectify and remediate and resolve their issues. I don't have to go into too much more detail than that. If people want information, I can give it, but it was basically a very quick action we had to take at that moment to ensure patient safety is really the bottom line. And I'll give you an update on that. They have remediation in process. Everything is going very well. The institution is helping. They do their narcotics through one of the Hudson Valley hospitals, and it's moving forward. Also under new business, I'm sure everybody received the blood products was finally put out by the state. Doesn't affect so much our pre-hospital care, it's mostly inter-facility transports, and the blood products recommendations have been put out and finally approved. Oh, sorry,
No, I mean, again, we were happy to finally see it come through, not happy to see how it came through. You know, for the most part, it is going to be almost like every service will have to negotiate with every hospital in the system, and it seems to be just something that I was wondering if there's any way we could regionalize some of this. I mean, we've talked to Lee about this, Lee Burns in Albany. It does seem like every single service, if there's 5 services doing transports from 11, 12 hospitals, each one of us has to go through the whole process with them for the same end result, which doesn't seem to be streamlining anything. In your opinion, is there any way that we would look at the region in some way? I lack a term other than regionalizing this.
I mean, I can ask them, my gut feeling is no. What do you guys think in the back there?
I don't know, to be honest with you.
Yeah, it was so hard to get this part out initially, just this part. I will bring it up at the meeting though. You know,
We
is
have to
that,
have an agreement, every hospital,
Yeah.
their blood bank, everything else, I go through, and it's all for the same purpose. And, some of the hospitals talking to scratch their heads already, so I'm not really sure. If not, I would ask that maybe the Remac physicians help us, you know, with contacts at their own hospitals to try to get this moving forward.
I think a lot of people were unaware that it didn't happen, to be honest with you. I don't think they ever thought that it was an issue. I think they probably thought that you guys always transported with blood, you know? If you think about it from a logistical point of view and the patient safety and patient necessity, but that's probably why they're scratching their heads, you know? Also, under new business, Karen put out the schedule for the Remac meeting dates. Please look at them and review them, make sure there's no problems with the dates, anything, so that we know in advance, and that we can keep our schedule and not have to, like, at the last minute change. Also, under new business, I received the resignation from Dr. Stuck this morning for medical director of the region. So that's a huge loss for us. Eric's been here for a very long time. I don't know how many years, to be honest with you.
1990.
Yeah, it's gotta be at least, yeah, it's gotta be So, you know, he needs to pursue other things. He will be moving forward, but that means that the position of the medical director of the region will be vacant. And I'm going to make a suggestion to the REMSCO, because that's who officially makes the designation and such. So I think that anyone who's interested, you know, should definitely make it themselves known to the office. When's the next REMSCO meeting? Next Wednesday?
December.
December, the third Wednesday, second Wednesday? Third. So that maybe we could put some names forward before that meeting. So if anyone's interested, as the medical director, you know, you're really responsible for the protocols for what happens under the facilitation of all as it means. But Eric's been doing it a long time, and I understand. I mean, I totally, you know, can see that people need to move on. But it would also be good for the region, because then we have new faces, new people. So Dr. Papish, I'm gonna recommend your name.
I was just telling him that. I'll second that.
You did a pretty good job running the meeting before, though.
I thought you were all forget about that. I can't.
But, you know, just, I think anyone is definitely, you know, if you're interested, it's, half the battle is really having a passion and an interest in wanting to facilitate and improve the care, and to, you know, have really some medical direction. There's times that the issue is extremely poignant, and other times it's not a lot. A lot can be done electronically, a lot can be done through other formats. And you know, the office has my phone and email, and they don't use it that often, really rarely. It's really an easy job. I used to do both of them for a while, but I definitely don't want to do that again. And I think it's just not good to have it be the same person. I think you need to have two different people, and you need to always have two, you know, you need to have people looking at things. So we want to thank Eric for all of his years of work and input. But as that being said, we will be looking for people to volunteer up their name for it. Okay, also, we'll be kind of revamping evaluation committee too. Evaluation committee is really just members of the committee to sit forth. It has to be, you know, someone from the office. The medical director has to be there, and so it's really quite easy for that to move forward. Under pad, EpiPen, and albuterol, nothing. Oh no, we had one pad site. One pad site to move forward. Foundry, I forget what it was, the name of the foundry, here right in Rock Tavern, New York.
Talix Foundry.
Is an institution.
Talix, T-A-L-L-I-X.
Going to put forth a pad site, so that paperwork's being forwarded on to the state. And that brings us to open forum. Anybody have anything they want to bring up this morning?
So, one thing I wanted to bring up to a vote to see if there would be interest in forming a tag that would be joint between Hudson Valley and Westchester Remac to have interfacility transport protocols. Because there's still a lot of confusion about what should happen in these transports. The issue with C-spine that happens, there's a lot of other similar issues, whether it's appropriate fluids on a child or a baby, or, you know, as the other, like patients who are getting TBA, I've seen a lot of permutations of things that I think we could probably improve and you know, help patient care. I think that it'd be great to have it with both regions together, just from a manpower perspective. And so I want to see if we can vote to form a formal tag and hopefully get some members and then start divvying up the work.
Well, I think, you know, notoriously, and I'll speak for Eric, you know, through the 20 years, they've never wanted to put their toe in that water, you know, of governing interfacility transports. When we joined the collaborative committee, they did have that small oversight, basic protocol there, but it really doesn't delve into how much nuances there are, and it is under the, sending facility, and that I'm sure you get so much variation. I can go either way on it. I definitely think having guidelines for people to use or things for them to review to is always helpful, and I think it's, in the best patient care interest. I think the problem becomes some of the providers that perform these interfacility transports, have bucked this in the past because they think we're dictating what they should do, but I think from a medical direction and from our input, we should have that input and should make sure there's patient safety and there are standards and that things are met, and we do, and it would be nice to do things similarly, just like we're doing the collaborative. Why can't we all kind of be on the same page and make sure? And maybe the doctor doesn't really know, and maybe if they had a piece of paper that said, this is how we like to do it, it'd be more helpful for them.
Well, certainly, I think everyone would always agree that the medical control provided by the sending doctor would trump anything that would be in a interfacility protocol. This would be kind of what would be in the absence of direction, would be the standard, or it would be, hey, I'm gonna follow the existing protocol, and say, sure, that sounds great.
And kind of rudimentary things so that they basically have a template and a concrete foundation to start on. And there's always gonna be some variation from it or things that add into it, but at least I like that idea.
What other people think?
I think for any transfer that we're doing, obviously, we have to have orders before we leave.
Yes.
And those are usually written orders by the transferring physician. Are they always crystal clear? No. A lot of times, as you write, follow AELS protocols, yes, they are. But it really doesn't involve, if you think about it, it's between a unit at a hospital going to another unit at another hospital. It really doesn't involve the EMS type protocols per se. We use a lot of it, but can argue both sides of the cases, but we have had some issues where we're dealing with a private physician who wants his orders, doesn't want certain things done, wants other things done, and that's where we have to go with it. That has created a problem, though, when we do get into trouble. If they transfer out a patient, now we have to close, either call into a hospital for medical control somewhere down the line, or dive into a hospital. And I know the physicians have felt, this is not in my charge here, but this is a private transfer almost, and so it has, we've had a lot of discussion with this at a state level about it. Some regions have done it, some have not done it well. Others have shied off of it. Normally, we've had most of the discussion centered around Albany Med, quite honestly, in the past, because of similar role in life, being the receiving point of so much. But again, a lot of our transfers don't stay within the region, they're going to other urban areas, New York City, Boston,
Yeah, so I think it's a great idea, I think, to improve quality of care, but there's the complicating factor of the jurisdiction. We don't have the right really to kind of regulate it, but we certainly have the right and duty to say, hey, this is what we think we should be doing for interfacility transfers. So I think it's a good idea. Westchester gets the bulk of the transfers from this region. There's Hackensack, there are other facilities too in other states that get some of the transfers as well too. So to the extent you can involve some of them, it would be helpful.
Well, I mean, I think that for patients going to New Jersey, it's entirely different.
No, but we can still say these are our recommendations for
Yeah.
some of the interfacility transfers, and what does it, if we send somebody to Yale or Connecticut.
Sure.
I'd be willing to sit on
Right, yeah,
that tack.
I think it's.
I think we do need to have some representation, and I think it makes sense, Westchester and Hudson Valley, that we do this open communication and form something together that works for both of us. Mr. Murphy.
I think it's a good idea. I think it's positive for patient care and universality. I think what we need to think about is a few things. You use the term protocol, perhaps guidelines is, it's a matter of semantics, but it's a better term. I think there are some universal guidelines that should be put forth, especially with regard to medications that practitioners may not be familiar with all the time. Both the provider who's doing the transport and the sending physician who may be sending the person. So if there was a universal dosage and guidelines of transporting a patient with TPA or propofol or whatever it may be, then that would be positive for patient care. And I think that if you do establish a tag, Obviously, it should be physician-based, but I think you need some representation for logistics and other nuances of the actual folks that are doing the transports.
Dr. Brooks?
You know, we've been banting about this for about 20 years. ER to ER is a separate sort of transport, and we as the physician control physicians are actively involved in it. We know the medications, and it's a little bit easier, and guidelines would be easier. When you deal with the intra-facility transports from unit to unit upstairs, you have to be careful. We used to have that in Alamo. There's a whole separate course the transporters took regarding nitro drips and not propofol at the time, but similar sort of medications that were out of protocol for our involvement here. And if we get involved in those transports outside of ALS, if something happens, we're open to liability with medications that we're usually not medical directors or medical control for. So we're just be a little bit leery of the inter-facility transports from an upstairs unit to an upstairs unit. I mean, it's just thought, not that it shouldn't be done, not that we shouldn't be involved in that, but there's a lot of medication and stuff that we're usually not involved with. We have our meds, and that's what we deal with. We teach our medics that. But when you're dealing with propofol, when you're dealing with tridal drips, and there's other sorts of weird antiarrhythmics and a bunch of other medication, then it's going to be on us to accept them, to make sure they get taught. And so I think it's different from ER to ER versus, and not that the facility transports upstairs from unit to unit shouldn't be addressed, but we have to watch our involvement in it, and we've been through this for years. It's just a caution.
I think that is, you know, definitely an issue, because sometimes you don't know what people are doing upstairs, but I still think we need to protect our medics who are out there. They do need to involve medical control at some point, and I think, if there's a problem, it's sometimes too late. You know, it's better to know it on the front end, but if we had loose guidelines, not loose per se, but some kind of guideline for them to go by and to be able to even have a mechanism of who to call and what to do is also a positive.
And they're not available. A lot of times the private docs aren't available.
Right,
Yeah,
so that.
exactly, the city doctor all of a sudden.
Yeah, they need to have somebody
Yeah.
that they can
And you have
count on
no
and rely
idea, yeah.
upon, you know, to help and to intercede, because that's what we're here for, is to help them out. And I think that was the premise behind the original collaborative protocol, was to help protect the medic and have, you know, an avenue for them to have some backup and support. And if they're uncomfortable, they need to be able to talk to somebody and say, hey, this doesn't make any sense to me. You know, and this may be a drug I don't know, this may be, they just did this process to this guy and I have no idea what this is, you know, so those things I think are important.
The question is whether they should be transporting somebody with a medication on board in a drip that they don't know. And that's the question. Like, again, as we did in Alamo, there's a whole special class that people had to take and they had to sign off on for a transport team. So under medical directions, it's scary, you know, it's a lot more complicated, so.
Well, I mean, this will help define the
Yeah.
scope better. So, I mean, this process will be a process where we would actually help define what are the medications that your guys would feel comfortable using, and what are the ones that maybe, you know, we don't include it. If we don't include it, there's a reason why we don't include it.
So nationally, there's no accepted curriculum for a paramedic doing interfacility transports. Each state has the choice whether or not they designate a paramedic at a level, you know, above, if you will, don't take that critically, but above the level of a 911 paramedic. And New York State has chosen not to do that. Other states have, so there's many state courses and guidelines you can look at, including next door in Connecticut. Then there are 2 national certifications for a paramedic, CCPC, which is a certified critical care paramedic, and a FPC, a certified flight paramedic. Both of those are examination courses to validate a knowledge base. Neither of those have an educational requirement to sit for the course. So this is a void in the evolution of the role of paramedic in out-of-hospital care. And it's been one that New York has avoided. As you said, Fran, has this Remac for a while, and the REMSCO, and everyone has avoided it because it isn't easy. And if you can provide tools for the sending physician to use to guide the providers on how to care for some of these critical patients, that would be valuable. And then also, who do you call when you get into trouble? Solidifying that system would be valuable, and it's likely going to be the receiving doctor, if that receiving doctor is willing to take phone calls and manage an out-of-hospital transport, which is variable willingness, as we all know. That's why myself and my colleagues in the air transport world are usually medical control for our providers, and we provide them with guidelines that are pretty robust that thankfully the Remacs have allowed us to have our providers have different guidelines and different medical control. And I think part of that is because there's been no other option. There's been no other New York State or REMSCO-sponsored solution. So I'll be part of the tag, of course.
I was just gonna say, does that mean you're volunteering? There you go, there you go.
So I've been doing it for years, but...
No, but I think it's good because it gives the other advent, and you'll have stuff that's already out there. So again, some of the stuff is already, there that you use in flight that we can, modify, adopt, or, incorporate.
And I'd love to, I'd love to have involvement from the agencies, because this is really just about protecting the medics, so that there's actually an idea of what actually is within the scope of this practice.
I think that's been the rub as far as the state, because I sat on this SCT committee at the state level, and the state health one was not going to get involved with another level of certification. And they do recognize that by definition, SCT, special care transport, is certainly requires care above the level of the paramedic. However, in that void between a regular paramedic and SCT lies a lot of 90% of the interfacility work. And so the state wasn't going to delve into, and that's why some regions did and some regions did not. And I think that just put in perspective too, if we do take a transfer out of the hospital, our medics have to be familiar with whatever the meds are that they're going to transfer, and have specific orders. When they affect the transport, and if they get into trouble, it's usually because the patient's condition has changed and now they are looking. So now that's usually when they either can try to call back to the transferring physician, or more likely are looking at calling medical control. And now it's not to protect the paramedic as much as to protect the patient, because we really have something that's untoward. What should we do? Because oftentimes that medical control physician has been put on the spot where hasn't seen this patient, hasn't seen the orders, doesn't know who's involved in it, and now you're asking them to interact with this transfer. So oftentimes we're better off when we actually come into the medical control hospital rather than say, I'm halfway between here and there, and what orders are going to give me. That's when I don't think, I can't speak for you guys, but I'm sure you don't like to have us calling you for orders on a patient you have nothing to do with. It's not even involving your facility. It's just because you happen to wear the role of the medical control facility close enough for us to call you that we're involving you.
I mean, I think we always have to, be there for the patient. So if you guys are in a transport, and you're headed down to, say, Westchester, for example, and you get, before the Tappan Zee Bridge and something happens, you gotta pull off and go to a facility and get help if you need help. And so I think this is all good communication, good, opening of discussion so that we have some kind of template, guideline, assistance, mechanism of what to do, some kind of thing for people to follow. So Dr. Holden, you're way up there in the north. You want to come on the committee too?
Sure.
Yeah, there we go. We're gonna and that way, we have the place covered. We try to get, because there's so many facility transports occur, and I think that opening this conversation is good. I think it's all good for everybody involved.
Albany should be involved.
They are actually, that is one of the things they're looking at is, do you make a protocol for interfacility transports? How do you do this, that whole conversation of Article 28 facilities sending patients and et cetera, but it's a thing that everybody's looking at right now because it is very, very important. So I think we can start the discussion, form a tag, and start looking at it and make, some kind of headway.
So if we vote, let's inform it, we need to vote?
No, we can just make it, yeah.
Sounds good.
Yeah. We'll just, make sure we put that in the minutes, and those people who so nicely volunteered. Okay, next, anything else in the open forum? Yes?
Just a quick announcement, this Saturday, November 7th, we're having the EMS Connections Conference at the Dutchess Community College. I think there are a whole panel of physicians that are going to be speaking there, Dr. Papish, Dr. Berkowitz, Dr. Brooks, myself. and it's for the community, so please help spread the word. Guy or Sharon are happy to email out flyers if you haven't received them already.
And that also means medical control contact hours.
Oh, was that like, how many hours?
I think it's
7 hours.
Yeah, so
We'd
that's-
love to have
that's
you guys.
huge.
We're gonna take care of food and all that good stuff, and it'd be a pleasure.
And so it's Saturday?
This Saturday.
Saturday, Dutchess Community College, I think 8 o'clock on.
Mr. Perry?
November 28th, Ulster's having their EMS teaching day at Mohawk.
Oh, wow. Do you have to pay the facility fee to get in there?
No, there's a $25 registration fee, includes 2 breaks and lunch and CMEs.
What's the date of that?
November 28th,
Saturday.
the Saturday following Thanksgiving.
Okay, so it's that Saturday, okay.
Yep.
How many CMEs in average?
There's 2 Mac, 2 medical, and 2 general. There'll be 6 CMEs.
6 CMEs. Okay, anything else in open forum?
Anybody else taking EMS boards in a week?
No.
Last year.
Took a recert again, my third recert.
No, he's saying EMS certification. I know that, Albany is putting in their, what is it, the CMGE, I'm misquoting the organization, to have a,
ACGME.
ECGME, I forgot that
Yeah.
one letter, final stages of having a EMS fellowship.
Oh, that's amazing. My program got reviewed in New Jersey, the fellowship that I run, and it's very exciting.
Yeah,
And stressful.
so they're putting forth the final stages of that so that they could hopefully have an EMS fellowship. So that's, you guys, just any doc who goes through, their residency program in emergency medicine, you can go on to do fellowships, and one of them is to do EMS, and so that's what they're applying for. Okay, anything else? So homework for next time, think about becoming the medical director, make sure you review the times for our new meetings, review the pie diagram, because we'll talk about that next time for our region, and we can move forward on it. And just, reviewing the disposition designation. And I think that's it for now, and the new tag that's been formed. Can I have a motion to adjourn the meeting? And second? All right. Thank you, everybody, for coming. This was a great attendance. I appreciate it.